Good morning, everybody. Almost good afternoon. It's a great pleasure to be with you today. I am the second fan of autogenous bone graft harvest from the maxillary tuberosity this morning. After Sujana, it shows a very brilliant clinical case. And I'm going from now on to go one step further to do the bone reconstruction and immediate provisionalization in one single procedure. To do that, I'm going to discuss with you about two powerful techniques. Let's put it together. The title of my lecture is Using the IDR Technique Combined with Osseodensification in Periodontally Compromised Sockets. This is my office there in Brazil. I have here 7 chairs. I have my surgical center, my lab, and also my study center. And I usually give a 3-day course 4 times a year in my private office. If you have the opportunity to come to Brazil, please visit us. It will be a great pleasure to have you there. I would like to say many thanks to my team, my wife, that fortunately is with me today, my partner, Dr. Periodontally, and Dr. Luis Antonio Violin. These are the people who helped me in developing the IDR technique. And I'm going to talk to you today about bone grafting at the time of immediate implant placement and provisionalization in compromised alveolar socket. This technique was called more than 12 years ago as immediate dentoalveolar restoration, or IDR, immediately loaded implants in compromised alveolar sockets. Here we have a case that we applied this technique before, 3 months after the surgery, after 4 months, and after 8 years. But what we did here, we extract 2 hopeless teeth, we insert the implant in the right position, we restore the buccal wall that the patient had lost in both central incisors. We manufacture the provisional restoration immediately. And 3 months later, if we make a comparison in the day of the surgery and after 3 months, you can see the maintenance of the anatomical contour of soft tissue. And if you make the comparison, the pre-op, and after 8 years, you can see the leveling. We still have the leveling of gingival margin and the improvement at the papillary height. This is the immediate dentoalveolar restoration concept. This is a minimally invasive approach. This is a flapless surgery. But all credit is go to the Mother Nature, because we use bone biology from the same patient as a bone transplant. We take the bone from the tuberosity. We reshape this graft according to the defect configuration. And we use this bone as a biological membrane in order to restore the wall or the walls that the patient had lost, regardless of the extension of the bone defect. And how about the IDR literature? We have already published 21 articles about this topic. 1 more article was recently accepted for publication. And we have chapters in 6 books, in 6 different authors around the world. And we have our book that was published in Portuguese, in Spanish, in English, and also in Mandarin language by Quintessence published. If you are interested in go deeper and go a little bit further about the IDR technique, please go to Quintessence. And we have 5 keys to immediate dentoalveolar restoration in aesthetic areas. The first one, and the most important one, is the implant stability. The second one is the implant position. We have to put the implant in the frontal area from the canine to both sides, from the right canine to the left canine, always in the palatal wall anchorage. The third key is about the gap to be left between the inner part of the soft tissue and the outer portion of the implant. The fourth key is about the thickness of the buccal bone plate. And the last but not the least important is the emergence profile. During my speech, I'm going to talk about these 5 keys in order to succeed with the IDR technique. And the main focus of my lecture is to treat cases like this. Here we have 2 central incisors condemned to be extracted. They lost the buccal wall beyond the root apex, as you can see before, and we confirmed after the extraction. We have a very poor quality of soft tissue. And 3 years after applying the IDR technique, you can see the balance between the gingival margin and the papillary height. This is the main goal of the IDR technique, to keep and to improve the position of the gingival margin and the papillary height. But we know that we have compromised sockets, but how about the bone graft to be used in order to restore these defects? Before we go to the graft, let's evaluate these 2 clinical images and the CBCT scan. The question is, what is missing here? I know you agree with me that it's missing the buccal wall. If you only extract this tooth, you would have the tissue shrinkage towards to the defect. But our aim is to keep the soft tissue exactly in the same position in order to hold the soft tissue. So we must graft the bone defect to hold the soft tissue in its original position. But you have to ask yourself, what about bone formation around the implants? Which kind of bone do you want to have around your implants in a long-term follow-up? We have many options in the market. We have many options inside the patient's mouth. But I'm going to discuss with you about these 3 kinds of graft. Here we have 2, but let's add another one. We have the 2 kinds of autogenous bone graft plus the biomaterial. We have huge difference between these 3 kinds of graft. Of course, the main difference is about the color, but not only about that. Talk about the clinical applications. Biomaterial, according to the literature, is mostly used for filling the gaps in intact socket. But in compromised socket, it's recommended by the literature to open a flap in order to apply guided bone regeneration in combination with membranes. Bone graft that we harvest from retromolar area, we must raise the flap in order to screw the graft. But bone graft that we harvest from tuberosity, we don't need to open a flap. This is a blinded surgery. And if you start talking about graft vascularization, in biomaterial, we cannot find any viable cells. Bone graft from retromolar area, a low number of viable cells. It's because it's more cortical. And bone graft that we harvest from tuberosity, we would find a high number of viable cells. In the end of my presentation, I'm going to talk to you about bone biology. But according to the literature, when we use biomaterial, we should wait between 7 and 8 months in order to go to the next stage. When we use bone graft from retromolar area, we should wait between 5 and 6 months. But when we use bone graft from the tuberosity, according to our research, we have to wait at the most 4 months, between 3 and 4 months in order to take the impression and to make the final restoration. So when we either using biomaterial or graft from retromolar area, everything is going to be solved in 2 or 3 steps. But when we use bone graft from the tuberosity, everything is going to be solved in 1 single shot. This is what, in my humble opinion, this is what works best. The next question is, what's the importance of using a graft as a natural scaffold filled with osteoblastic cells and growth factors? If the patient lost, as you can see here, the buccal wall, the question is, why not to use a piece of bone as a natural scaffold with the cortical and cancellous bone in order to replace the buccal wall that the patient had lost? And we can use this cortical cancellous block as a bone wall, as a biological membrane, in order to restore the wall or the walls that the patient had lost. This is the result that we are looking for. And the main aim of using this principle, this concept, is to have a bulky soft tissue along the months and along the years. But let's carry on talk about donor graft area for the execution of the IDR technique. This graft has some special characteristics. From the tuberosity, we may have cancellous bone, cortical bone, or connective tissue graft, or a piece of connective tissue, cortical, and cancellous bone in one single piece. Due to its malleability, it's very easy to be manipulated. The endosteum has a high capacity of revascularization and the capacity to keep its vitality. And release growth factors to the receptor side if we have a fast manipulation and less exposure of this graft. This is why we recommend you to do a quick manipulation. As soon as we harvest bone from the tuberosity, we reshape this graft according to the defect configuration using special tools, like here we are using a rounder. And immediately after that, we use this piece of cortical cancellous graft in order to restore the wall that the patient had lost. But the main aim of using this to do a quick manipulation is to keep the cell's vitality in the graft from the donor side to the receptor side. And this graft has some special advantages. For example, we may have faster bone graft incorporation, quicker revascularization, mechanical resistance in 3 months. In 3 months, we would find the final hardness of this bone. Low morbidity. Talk about morbidity, as Jana said. We will always expect a very, very low morbidity, regardless the amount of bone harvest from the tuberosity. And the tuberosity can provide various types of graft, as for example, connective tissue graft, particulate bone graft, cortical cancellous graft, cortical cancellous block, or a triple graft. Before we go to the applications, the IDR applications, let's talk about one of the main topics to succeed with the IDR technique. How about the gap to be left between the implant and the inner part of the soft tissue in order to succeed not only with the IDR technique, but all the techniques available in the literature? We suggest to the international scientific community, in 2014, we developed a protocol for selection of implant diameter in post-extraction sockets. Here we have this case presented, number 8, condemned to extracted. We did impression, we got the stone cast, and we did a surgery in this plaster model in order to remove this tooth, neither touching the gingival margin at the buccal aspect nor at the palatal aspect. And over this stone cast, now we are able to measure the distance between the inner part of soft tissue from the buccal to the palatal aspect. But we can also use a soft tissue enhancement sub-CT scan. And we can measure here the inner part of soft tissue from the buccal to the palatal aspect, the same way that we do over the stone cast. So we have these two methodologies in order to select the correct implant diameter. And the implant has to be inserted always in the palatal wall anchorage in order to have the gap around 3 millimeters, regardless of the tooth to be replaced, upper, down, anterior, or posterior, doesn't matter. That's the way that we select the implant diameter. We use the buccal palatal distance of the socket in order to select the correct implant diameter. And this is the rule that we've been using for the last 8 years. When this distance is less than 7 millimeters, the implant to be selected should be narrow. When this distance is equal to 7 millimeters, the implant to be selected should be a regular platform. And when we have more than 7 millimeters, that's the only way to use a wide platform. Let's see an example. Here we have this young girl. She presented the number 9, condemned to be extracted due to root resorption. We evaluate the dimensions, the buccal palatal distal dimensions from the inner part of soft tissue from the buccal to the palatal aspect. As we have 7 millimeters, it's very easy to select the correct implant diameter. Here we did a digital planning, a prosthetically driven digital planning. And through this exam, we can plan how to obtain a screw provisional restoration. This is what we like most. Always manufacture a screw provisional restoration immediately over the implant. But how to do it accurately? We should use a prosthetically driven digital planning. Through this exam, we can not only to select the implant diameter, but we can previously plan the dimensions of the gap to be left between the outer portion of the implant and the inner part of soft tissue. Here, we remove this tooth. We extract this tooth as traumatically as we could. We insert the surgical guide. We did the site preparation. This is a fully guided surgery. We insert the implant. We made the provisional restoration using the same crown from the patient, and we did a hard tissue reconstruction. We harvest bone from the tuberosity right behind the second molar, and we use this bone in order to restore the defect at the buccal side. And we left, as I told you before, a gap around 3 millimeters. 3 months later, we have the soft tissue maintenance. If we remove this provisional crown, the soft tissue won't change the position because we have bone underneath the soft tissue in order to keep the soft tissue in the same position. Let's do a simulation. Let's understand how important it is to have a correct emergence profile in order to succeed with this technique. Here we have the CBCT scan that was taken after 4 months. You evaluate the CBCT scan, pay attention that the bone graft that we had placed over the implant platform is still remain and remodel over the implant platform. Here we have the soft tissue position. Behind the soft tissue, we left intentionally 3 millimeters gap. We fully fill these gaps with particulate bone, harvest from the tuberosity. So we have here the hard tissue. And this is the key. This is the key. What we call a soft tissue gap. We intentionally leave this gap always. This is what we call a magic triangle. Because when we leave this under contour in the provisional restoration at the buccal aspect and the proximal aspect, like this, a slightly concavity, we allow the soft tissue ingrowth in that area. But the main aim of doing that is to have a thicker soft tissue along the months and along the years. Here we have our planning. From our planning to the execution, if we superimpose the execution over the planning, you can see that the implant was well placed, and we left intentionally this gap around 3 millimeters, and we have the bone stability at the buccal aspect. So after 3 months, we took the impression, we made the final restoration, again, with the ideal emergence profile. We reproduced exactly the same shape that we did in the provisional crown shape, we made in the final restoration. And this is the day that we delivered the final crown. And this is the post-op after 3 years. You can see here the maintenance of the anatomical contour and the maintenance of the papillary height. This is the original article that was published in 2014. And we described this protocol either using a stone cast or a soft tissue cone-beam CT scan in order to help you how to select the correct implant diameter. But now let's evaluate the regeneration process of the bone grafted. Here we have the number 5 condemned to be extracted due to the fracture. We remove this tooth, we insert the implant in the right position. We left a gap around 3 millimeters, as you can see here. We made the provisional restoration immediately, of course, out of occlusion, always. In 3 months, we removed the provisional restoration, and you can see here the maintenance of the anatomical contour of soft tissue. We took the impression, and we made the final restoration. As simple as possible. But let's take a look at this CBCT scan that were taken before, 1 week after the procedure, 2 months, 4 months, and after 4 years. Pay attention that the dimensions of the bone grafted after 1 week, we found the same dimension after 4 years. But I want to call your attention that after 2 months, we have the early bone remodeling process, and after 4 months, we have total bone incorporation. This is another article that was published by my team, my wife, and myself and my team. And we suggest to the international literature the new guidelines for selection of implant diameter during immediate implant placement and provisionalization in fresh extraction sockets. What we did here, we evaluate 20 clinical cases. All clinical cases presented total loss of the buccal bone wall. We apply the IDR technique. We restore the buccal wall using cortical cancellous graft harvest from the maxillary tuberosity. And we evaluate this clinical case for 3 years. But we evaluate the most important part of the implant, the corneal part of the implant, up to the implant platform, 2 millimeters above and 4 millimeters above. And the results are amazing because we got the stability of the 3 millimeters of bone regardless of the extension of the bone grafted. Let's see some indications of the IDR technique. Firstly, I'm gonna show you the traditional IDR protocol that we are able to manage at least 8% of the bone defect that the patient come to our office asking help. For example, this case, this was the first clinical case that we applied this technique. A big fistula could be seen. We extract this tooth, we clean the socket, we evaluate the dimensions of the defect. As you can see here, we install the implant, the palatal wall anchorage. We start the reconstruction with cortical cancellous graft at the buccal aspect, and we fully fill these gaps with particulate bone, both collected, harvest from the maxillary tuberosity, and we install the provisional restoration immediately out of occlusion. And you can see here, after 3 months, soft tissue completely healed and maintained in volume and in the papillary height. And we took the impression and we made the final restoration. This is the post-op after 12 years. We have the buccal wall completely stable, and we have more important than that is the maintenance of the anatomical contour of soft tissue and the papillary height. Here another example of the traditional protocol. This patient, she's a dentist, and she had an accident, and she presented the number 8 condemned to be extracted. She tried to save this tooth, but she did not succeed. And she had a total absence of the buccal wall. We extract this tooth. We confirmed the absence of the buccal wall, as you can see here. We installed the implant at the palatal wall anchorage. We intentionally left 3 millimeters of gap at the buccal aspect. We made the provisional restoration using the same crown from the patient, leaving an under contour, as you can see here, in order to promote a better soft tissue accommodation and ingrowth in that area, in the buccal and the proximal aspects. And we harvest bone graft from the tuberosity. To do that, we need previously a clinical assessment, an X-ray, and a CBCT from the tuberosity. That's one of the ways to harvest bone graft from the tuberosity. We usually do a posterior-anterior crestal incision, start in the last part of the tuberosity to the distal part of the last molar. And sometimes a vertical releasing incision is necessary, not all the times. Depends on the amount of bone that you need. That's the kit, that's the IDR kit. And we raise the flap, and we should see the field as much as you can. This is why we recommend you to do plenty of irrigation at this moment. And the chisel has to be placed as perpendicular as possible to the remaining bone. As soon as you go deepen approximately 2 or 3 millimeters, we change the angulation of the chisel. And after that, we can go until the planar length. This piece of bone, a double layer, a cortical cancellous graft, we are going to use to restore the buccal wall. And all bone that we harvest from the tuberosity, we insert in a container rich in blood. And we reshape the graft according to the defect configuration. And take a look that we also match the cervical portion of the graft with the outline of gingival margin, because we intend to restore the bone architecture, and we fully fill these gaps with particulate bone harvest from the same donor area. and we install the our screwed provisional restoration. This is what we call a soft tissue gap. And what we are expecting for about the soft tissue management, talk about the position of the gingival margin. Take a look. We put the implant 3 millimeters below gingival margin, but we always put the graft 2 millimeters below gingival margin. So if we did it, we are expecting some soft tissue growth coronally. This is what we are always expect when we change the position of the graft coronally. So we wait for 3 months. After 3 months, to push the soft tissue apically, we added composite resin every once a week for 3 or 4 weeks. After we got it, we removed the provisional restoration, and you can see here the maintenance of the papillary height and the maintenance of volume of soft tissue. So at this moment, we took the impression, we made a customized zirconia abutment, and we installed the final restoration. And this is the post-op after 6 years. We have the maintenance of volume of soft tissue, and you cannot see anymore the connection between the remaining bone and the bone grafted. But let's talk about the other 20% of our clinical cases that usually come to our daily practice. From now on, I'm going to discuss with you about the 6 challenges in implant dentistry. The first one, we have an intact socket, but we have a very poor bone density, a bone density type 4. But I intend, as I usually do, to install the implant and to make my provisional restoration immediately. This is what I really like most. The second one, the second challenge, we have another intact socket, but how to do it all with this low remaining bone beyond the root apex. Number 3, we have an infection, we have a compromised socket, we have the partial loss of the buccal wall. Number 4, how to treat such a very challenging clinical case like this. We have the number 3, but we have only this remaining bone at the interdental septus. It was missing the buccal and the palatal wall. How to do it all in one single step? Let's make things a little bit worse. Here we have number 4, condemned to be extracted, but we have only this remaining bone in order to hold the implant for primary stability. And the last, this is the most challenging that I'm going to show you today, when it's missing only 1 millimeter of bone available beyond the root apex. There is no walls around this tooth. And the question is, how to do it all in one single step applying flapless surgery? I'm going to discuss with you from now on the combination of the IDR technique with osseodensification, the technique plus the technology. The first clinical case, let's answer this question: how to improve implant primary stability and low bone quality. Just to keep in mind that all this clinical case, I intend to install the implant to get very good primary stability, to make my provisional restoration and bone reconstruction at the same time. Let's see what we did in this case. We have number 8. But pay attention that we have an extremely thin periodontal biotype. As it was remaining the crystal bone, we treat this case as an intact socket. And this patient presents a low bone density. So, summarizing, we extracted tooth as traumatically as we could. As you can see here, we have the maintenance of the anatomical contour of soft tissue. This is the X-ray that I took right after tooth extraction. We went to the tuberosity. We harvest bone. We crush this bone as much as we could because we intend not, in this case, not to reconstruct the defect, but to fill the gaps because we treat this case as an intact socket. And we did this suture. But pay attention what we did here. We did the site preparation in a counterclockwise rotation, following the same rules that we've been learning in the last 2 days. We left the drill in position, and we used this drill as a space maintainer, and we fully filled these gaps around the drill. And you can see here the X-ray before and after bone filling, and you can see that the bone was well filled, and we didn't leave any empty space. When we left some empty space, we would expect some bone loss. So we removed the drill. This is the X-ray that was taken right after bone filling. We installed the implant, and the implant packed and condensed bone laterally and also apically. And I want to call your attention to the 3 millimeters of gap that we left between the implant and the inner part of soft tissue, the implant and the inner part of soft tissue. And we got primary stability over 45 Newton centimeter. We use the same crown from the patient in order to make the provisional restoration. This is what I really like most, to do a screw provisional restoration. And if we do a simulation in this provisional crown, you can see the 3 millimeters of gap that we left at the buccal aspect. This is the immediate X-ray. You can see that we put bone over the implant platform, all over the head of the implant, as you can see here and here. 3 months later, we have the soft tissue completely healed and maintained. And this is the CBCT scan that was taken after 3 months. Let's evaluate the CBCT scan. Take a look that we left bone over the implant platform, and the bone remodeled over the implant platform. If we measure the thickness, if we make a comparison before and after, you can see the improvement, of course, of the new buccal bone wall. And you can see here the 3 millimeters of this bone is still stable, and the thickness of soft tissue. This is why I recommend you to use a soft tissue CBCT scan in order to evaluate not only the thickness of the buccal wall, but also the thickness of soft tissue. This is real. So we remove the provisional restoration, and we evaluate the soft tissue thickness, and you can see here around 4 millimeters in thickness. But let's see how we started. We have barely 0.5 millimeters in thickness, and we didn't add any connective tissue graft. And in this case, we did an IDR technique plus the osseodensification. Let's follow what we did. We had an intact socket. We did site preparation, bone filling. We had our implant bed. We installed the implant, and we have the soft tissue maintenance. And we improved the periodontal biotype of this number 9. But why it happens? It's because of that. If we have bone at the buccal aspect, we do not need to compensate with soft tissue graft. This is what we believe. This is the concept that we've been working for the last more than 12 years. The second challenge, how to improve implant primary stability in case with remaining bone, low remaining bone, and intact socket. Take a look how to deal with a very challenging clinical case like this. I can do socket preservation. I can stage, but I can, if I use the right tools, I can not only to install the implant at this moment, but I can make my provisional restoration and to keep the soft tissue in order to avoid the second stage, in order to avoid to open a flap. It's because when we open the flap more than once, we would expect some unpredictability. Talk about the gingival margin and the papillary height position. This is what I really don't like. So what we did here, we went to the tuberosity, we harvest bone, we crushed this bone as much as we could. We fully filled these gaps with particulate bone. As you can see here, the bone particles inside the socket. And after that, we did the site preparation in a counterclockwise rotation since the beginning to the end, of course. This is the drill inside the hole. And we install the implant. And you can see the primary stability around 50 Newton centimeter. If I have primary stability over 30, I go ahead and I am able to make my provisional restoration. I use the same crown from the patient, and I left this, I left this provisional crown shorter than the neighboring teeth in order to protect this tooth from the occlusion. And this is the 3 months follow-up. We remove the provisional restoration, and I am able from now on to take the impression in an analogical way or digital way. Right now, doesn't matter. But the most important aspect to be considered here is the maintenance of the volume and the thickness of this new buccal bone wall. And we are able to see the presence of the bundle bone at the buccal aspect. And here we apply the IDR technique plus the osseodensification. We did a bone filling, implant site preparation, implant installation, and soft tissue maintenance. And you can also see here the improvement in soft tissue thickness. So at this moment, after 3 months, we took the impression and we made the final restoration. But I am also calling your attention to the right implant position. If you do some mistake about the implant position, don't believe in miracle. Bone that we harvest from tuberosity don't do any miracle. We have to respect the rules. This X-ray was taken after final crown installation, but pay attention to the CBCT scan that was taken after 2 years. If we make a comparison before and after, if we do the measurements, measuring the buccal palatal distance of the socket, what can you notice here? If this distance is very similar as it is, what does it mean? That we didn't lose volume in the soft tissue. And take a look at the improvement in soft tissue thickness before and after. The third challenge. How to improve implant primary stability in condemned tooth in combination with bone loss. Here we have a very poor quality of soft tissue due to, we have the fracture, the root fracture, we have the abscess, we have fistula, and it was missing the buccal wall partially. And we treat this case, of course, as a compromised socket. Compromised socket means that I need to do a bone reconstruction instead of bone filling. And we probe the socket, and you can see here how thin the soft tissue is. We can see through the gingiva the periodontal probe. And in case like this, according to our protocol, we prescribe antibiotic therapy 5 days prior to the procedure plus 7 days later in order to improve the soft tissue condition and to avoid any complication. So we extract the tooth. We confirmed here the absence of the buccal wall. We measured the thickness. Take a look at the thickness, barely 0.5 millimeters in thickness. And this is the key. We did the site preparation using the drills from the first to the last drill, but we have a very low bone density. And we tried to stabilize the implant, but we did not succeed. We stepped back, we removed the implant, we put in the housing, and we went into the tuberosity. We harvest bone, here a piece of corticocancellous graft plus particulate bone. We immerse this bone in a container rich in blood. This is what we really like. And we start the reconstruction. Firstly, we restore the buccal wall using buccal corticocancellous graft. As you can see here, during the graft insertion. And after that, we pack bone particles, only bone particles, small particles, in order to fully fill these gaps. As you can see through this X-ray, right after bone reconstruction, we fully fill the socket. Now, if we press the periodontal probe at the buccal side, the soft tissue won't change. It's because we have bone behind, underneath the soft tissue. We did the site preparation again, using denser drills in a counterclockwise rotation. And we use this drill as a space maintainer. And the site preparation, with the site preparation, we create a smaller hole than the drilling due to the bone plasticity. And we wait for some minutes in order to, before we insert the implant, and we reinstall the same implant that didn't stabilize before. And you can see here the 3 millimeters of gap to be left between the implant and the inner part of soft tissue. Primary stability over 40 Newton centimeters. Let's go ahead. Let's make the provisional restoration. I screwed the provisional restoration out of occlusion. And 3 months later, we have soft tissue completely healed around this implant. But that's the key. The space that we left intentionally at the buccal aspect of our provisional restoration. And we left this under contour that allows us to have a thicker soft tissue at the buccal side. So more important than one abutment one time is the thicker soft tissue every single time. This is the sequence. We had a bone defect. We did the bone reconstruction, the site preparation, implant installation, and soft tissue maintenance. And you can see the improvement and the soft tissue thickness before and after. So after 3 months, we took the impression, we made the final restoration with ideal emergence profile. We reproduced the same emergence profile that we had in the provisional crown in the final restoration. And we can see here the maintenance of the anatomical contour. This is the X-ray that was taken immediately after final crown insertion. And this is the post-op after 2 years. Take a look what happened. We have here the new buccal wall completely remodeled. We have the corticalization of this new buccal wall. And if we make a comparison before and after, and the bone graft that we had placed over the implant platform still remain and remodel over the implant platform. And we have the 3 millimeters of this new facial wall. The fourth challenge, how to improve implant primary stability in condemned tooth in combination with severe bone loss in periodontally compromised site. Like this case, this patient had a huge problem in number 3. This patient lost not only the buccal wall, but also the palatal wall. And we struck this tooth as traumatically as we could. We kept the interdental septus as intact as possible. And we have this low remaining bone. If we use the site preparation, a clockwise rotation, we will waste the bone, the most important bone that we have. What we did, since the beginning to the end of this preparation, we use osseodensification. And you can see here that we increased the size of the hole, but we didn't waste any bone. The bone is still here, all around the site preparation. We increased the size, but the bone is still there. So we install the implant, and we have the bone all around the implant, at the head of the implant. Primary stability over 40. We went a step further. We did the bone reconstruction using autogenous bone graft harvest from the same side, right behind the second molar. We made the provisional restoration and pay attention to the implant position in the correct three-dimensional position, exactly in the center of the crown. And 3 months later, it's possible to notice here the new buccal wall, the new palatal wall, and bone all around this implant. In 3 months later, we took the impression and we made the final restoration. The fifth, here we have number 4, condemned to be extracted, and how to treat posterior condemned tooth with severe bone loss and low bone quality. And the second question is, how to improve implant primary stability in case with, it seems that there is no bone, like this case, in periodontally compromised site. Let's see what we did very quickly. We have the number 4, because condemned to be extracted. But pay attention to the X-ray. There is no bone beyond the root apex. It was confirmed to the CBCT scan. This is the remaining bone that we have available. We extract this tooth, and it's possible to see here how poor the soft tissue is. And we measure the socket. We have here around 7 millimeters height. And we evaluate the tuberosity clinically and tomographically. And through CBCT scan, we notice that we have a very good amount of available bone. We open a flap, and we harvest bone very close to the receptor area. We use chisels in order to harvest bone. And we also collect blood from the tuberosity at the same time using a syringe. And you can see here in this image before bone remodelation and after we crush the remaining bone and after we reshape the graft according to the different configuration. We inject this blood inside this container in order to keep this bone as wet as possible with blood. And we start the bone reconstruction. Firstly, we use buccal cortical cancellous block to restore the buccal wall. And after that, we fully fill these gaps with particulate bone. Fully fill until where? Take a look. If we intend to leave the graft 2 millimeters underneath the gingival, below gingival margin, that's the position of the graft to be placed. So here we are just moving bone from the tuberosity to the receptor site. And this is the X-ray that was taken immediately after bone reconstruction. And we start to do the site preparation after bone reconstruction in a very low speed, around 100 RPM, with no irrigation. And we are planning to leave at the buccal aspect 3 millimeters of bone. As you can see here, we went to the second drill, increased the diameter of the drill, and you can see here that we push up the sinus floor. And we use this drill as a space maintainer, and you can see here the new wall. It's still there. And take a look at the bone after being densified, laterally and also apically. The question is, can we use this approach using biomaterial? Of course not. Of course not. So we insert the implant. Here we confirm the gap, 3 millimeters gap at the buccal aspect. And we put graft over the implant platform, primary stability around 40 Newton centimeter. And we made the provisional restoration immediately. This is the X-ray that was taken right after provisional crown installation. And we insert the implant 10 millimeters height, 3 millimeters inside the sinus. And we did the suture in the donor area. This is the immediate post-op. And this is the immediate CBCT scan. Can you see here? My control is not working anymore. The thickness of the buccal wall. This is the immediate post-op. 3 months later, we remove this provisional restoration. Just make a comparison how everything started. We have a very poor quality of soft tissue, a very thin periodontal biotype. And here you can see not only the increase in thickness of this periodontal biotype, but also the maintenance of the anatomical contour of the soft tissue. 3 months post-op, make a comparison how everything started. You can see here a huge difference between one and each other. And we have the 3 millimeters of this new buccal bone wall. What we did here, we did a bone defect, we did bone reconstruction, site preparation, implant installation, and soft tissue maintenance. The same way that I showed before. We improved the periodontal biotype in terms of thickness. So at this point, we installed the scan body, we're scanning. And here we insert the final restoration. just remind you how everything started. This is before and after. And this is the X-ray that was taken after final crown installation. In the last clinical case, which bone graft material would be indicated to treat condemned tooth in combination with infected sites and severe bone loss? And we can consider that in this case we have no remaining bone. No remaining bone. Take a look what we did here again. Here we have a periodontally compromised socket. The periodontal pocket was around 12 millimeters in depth. We have a huge abscess. This is the extension of the bone defect, almost compromising the implant, the neighbor implant. This is the roots of the first molar. This is the sinus floor. And this is the CBCT scan. We can consider that we have no remaining bone. It's missing the buccal wall, it's missing partially the palatal wall, and we have just 1 millimeter bone at the apex. We prescribe antibiotic therapy. We clean the socket. We remove the tissue granulation. And you can see that it was worse than we would expect. We have a thin bone at the apex. So we harvest bone from the tuberose very close to the receptor area. All bone was inserted in a container, and we start reshaping this graft. Take a look that we crush the remaining graft, and we fully, before we insert the corticocancellous graft, we fully fill the apex of the defect with particulate bone. And after that, we install 2 pieces of corticocancellous graft. The first one to restore the buccal aspect, and the second one to restore the distal aspect. Let's see what we did here. Here again, we are moving bone from the donor side to the receptor side. But pay attention, just to keep in mind how everything started. Here we have the particulate bone plus a piece of corticocancellous graft in order to reduce the size of the socket in mesial-distal direction. But it's fundamental to insert this graft with the cortex turned toward to the remaining bone and the marrow portion to the future implant that is going to be placed there. After that, we did the site preparation in the counterclockwise rotation after bone reconstruction. And here we are taking advantage about the bone that we harvest from the tuberose plus the osseodensification concept. And we took advantage about the bone plastic deformation. And this is before and after site preparation. So the bone was densified laterally and also apically. And we push up this we push up the sinus floor 3 millimeters. And we insert the implant, and believe it or not, primary stability over 30 Newton centimeter. We went ahead, and we made our provisional restoration. We installed the titanium abutment. We used the same crown from the patient in order to make the provisional restoration shorter than the neighboring teeth in order to protect this tooth from the occlusion. And we did the suture in the donor area. And this is the CBCT scan that was taken immediately. We have bone all around this implant. And pay attention to the amount of bone that was packed beyond the implant apex in these true cross-sagittal images. 3 months later, we have the maintenance of the anatomical contour and the maintenance of the papillary height. This was the sequence. We had the bone defect. We did the bone reconstruction, site preparation, implant installation, and we have the improvement in soft tissue thickness. So in 3 months, we took the impression. In 3 months, we took the impression, and we made the final restoration. And you can see through this X-ray the amount of bone that was packed beyond the sinus floor. The sinus floor, it's still stable. And 2 years post-op, we have the maintenance of the anatomical contour of soft tissue. This is what we are looking for. And this is the post-op after 2 years. Make a comparison before and after. And pay attention that we have the bone completely remodeled between implants. And also, I want to call your attention that the bone that we had placed over the implant platform still remain and remodel over the implant platform. And everything was solved in one single procedure. This is the post-op after 3 years. Everything was going very well, but this is the CBCT scan that was taken after 3 years. Make a comparison how everything started. We can see here not only the presence of the bone all around this implant, but I want to also call your attention that the bone that we had placed over the implant platform remain and remodel over the implant platform in the buccal aspect, and also pay attention to the amount of bone that was packed and condensed at the apex of this implant. And take the home message, as Dr. Sala usually say, don't remove the bone, just move it. Take advantage about this bone that we harvest from the tuberosity in order to improve also primary stability. This is one article that was recently accepted for publication. I wrote this article in partnership with my wife and Dr. Salah Wise. The use of a immediate dentoalveolar restoration technique combined with osseodensification in periodontally compromised socket. It will be published very soon. Before I finish my task today, I would like to invite you to the next ISPRD event. Why I'm calling your attention about this? Because I'll be there, and I'll participate in this session with Todd Scheyer, Donald Klein, Sasha, Daniel Buzer, Joseph Kahn. It's a one-day session. It's a predictable regenerative and aesthetic outcomes. And not only to go there, but in this event, it will be published this book, Implant Therapy, under coordination Dr. Myron Ebbs and Hong Li Wang. And I wrote a chapter in this book, The Predictable Aesthetic Anterior Maxillary Reconstruction with Dental Implants and Maxillary Tuberosity Grafts. It will be published this June, from 6 to 9. And in this chapter, we described all about the indications related to the use of bone that we harvest from the maxillary tuberosity. Socket preservation, socket reconstruction, sinus lifting, guided bone regeneration, bone graft for thickness, and high immediate dentoalveolar restoration, and peri-implant bone regeneration. To finish my speech 2 minutes more, I would like to discuss with you about bone biology of this bone graft. And let's understand why this phenomenon can happen. Here we have, right after bone reconstruction, 1 week after bone reconstruction, the same dimensions that we had 1 week after the surgery, we found 6 years after the surgery. Here we have, let's come back 1 slide. Here we have a dry skull simulation. Let's remove a piece of bone from the tuberosity the same way that we harvest bone from the patient's mouth using a chisel. Here we did a microtomography, and take a look at the cortical layer is very thin, but the inner part we have the trabeculae. The trabeculae is highly porous. This is good, this is amazing. But let's evaluate the histology of this bone. Here we took some piece of cortical cancellous graft and we did a photomicrography, and through this exam, you can see clearly the cortical, the trabeculae, we can see the endosteum, and we can see also the periosteum covering this bone. But let's give you a zoom in this image. At the trabeculae position, we can see a good number of osteocytes, but at the endosteum, you can see a high number of cells ready to be transplanted from the donor side to the receptor side. And how about this bone after this bone is being crushed in order to fill the gaps? Here we took some piece of bone, and we evaluate this bone using a scanning electron microscopy. Giving a zoom in this image, we can clearly see here the Haversian canal. Let's carry on, zoom in this image, and let's pay attention just in this part of the image. Let's give a zoom in this area. Take a look at the screen. We have a huge number of cells, viable cells, fibrin-net, growth factors, and BMPs. So the tuberosity carried the 3 fundamental properties to bone repair process. Osteoconduction, we can use this bone as a framework. Osteoinduction, release growth factors to the receptor side. and osteogenesis, a lot of cells capable of a new bone formation. If we make a comparison between biomaterial and tuberosity, biomaterial is white and dry, while tuberosity is red and wet. And biomaterial only has these characteristics, osteoconduction, while tuberosity carries the two other fundamental properties to bone repair process, osteoinduction plus osteogenesis. This is why we select tuberosity as the main donor graft area. This is an article that was published in 2017 at the Journal of Integration, and we evaluated tuberosity clinically, tomographically, histologically, and through micro-CTs. And the final conclusion. When we use this methodology, we are able to minimize the number of surgical procedures. It's because it's a single procedure. We can use this bone as a biological membrane to prevent cells competition between hard and soft tissue. When we combine it with immediate provisionalization, we are able to promote an acceleration of bone graft and also the osseointegration. When we use a suitable emergence profile of the prosthetic crown, we promote an improvement of peri-implant tissue quality. When we use platform switching implant, we always expect the peri-implant bone stability. And when we use osseodensification, we have improvement at implant primary stability. And I think this technique has a high predictability. It's very simple to be reproducible. It represents low cost for the patient. And I think it fits very well what Dr. Brandenmark used to say for all of us, that less is more. I think everybody knows about this brand, isn't it? It's very well known here in the United States. In Brazil, it is. And we call them and we schedule a meeting with the owner of the company, and we request them to add something in the T-shirt, in the front and the back. In the front, the gap must be filled. In the back, with autogenous bone graft harvest from the maxillary tuberosity. Thank you very much for your kind attention and for your patience. Thank you.